Senator Briggs is recognized on Senate Bill 453. Amendment is 13472. And I think we do have testimony. Senator Briggs is recognized.
Yeah, thank you very much, Mr. Chairman. This bill deals with Tennessee licensing anesthetist assistants. And we've not had a license for this in the past. And I know one of the questions that I always ask when it's something new is, first of all, do we need to do something like this? Is there a need for those? We know from information that we're receiving from the American Hospital Association and even from talking with our local hospitals, our local doctors, our ambulatory surgery centers that, quite frankly, the need is great. I know that Senator Massey and all in the last week have talked with the 3 hospital systems where we live, and that was on their legislative agenda, that the need is so urgent that they have additional anesthetic services available. The second question, which is the most important, deals with patient safety and how are they trained. They're very similar to our certified nurse anesthetists, but they take completely different pathways. The pathway of an anesthesia assistant is they have to have an undergraduate degree, and incidentally, the undergraduate requirements, the prerequisites to go to this school is identical for those who go to medical school. This means a year of chemistry, a year of physics, a semester of calculus, a year of organic chemistry, and a semester of biochemistry. Some of the schools require them to take the graduate record exam. Some of the schools actually require them to take the medical college admissions test, which is the same test that physicians take. When they go to their school, they receive up to 600 hours of in-class training and then somewhere between 2,000 and 2,600 hours of clinical training. They usually do over 600 anesthetic cases during that training. So they appear to meet very rigorous training. When they finish, they have to pass a national examination for accreditation on graduating, and then they have to complete, depending on the state, 40 to 50 hours of continuing medical education, just like a physician does. Part of their licensing that is different than the CRNAs is that when they go to a facility where they're doing anesthetic, an anesthesiologist has to be present in the facility. With a CRNA, they have legally have more, and their license allows them to do more independent practice. And then the last part that I think we all have to be concerned about is, are we the first state to do this? And there's other states, the states, just to mention a few that surround Tennessee that already issue a license for this and allow them to practice, are Alabama, Florida, Georgia, Kentucky, Missouri, North Carolina, South Carolina, and Texas in the southeast. And we are going to have an anesthesiologist, and I think an actual anesthesia assistant from Georgia that wants to testify if the committee wants to hear them testify. But I also looked to see what the official statement was after the American Association of Anesthesiologists, who looked at both of those. And their conclusion was, the committee concludes that differences do exist between the pathway that anesthesiologists and assistants and CRNAs take with regard to educational program prerequisites, instruction, and requirements for supervision, but the committee found no evidence that any of these differences resulted in a disparity in knowledge base, technical skills, or quality of care when supervised by a physician. And with that, Mr. Chairman and committee, is the information that I have, and I'm open for questions or open for testimony.
All right, do I have a motion on the bill? Motion on the bill. It's been moved by Senator Reeves, seconded by Senator Hale. We do have an amendment that would not make the bill, but would add to the bill. If you would explain the amendment.
Actually, I think the amendment makes the bill. They combined an amendment, so I think it's one amendment now in there. Okay. What we did also with one of the amendments is that there was an addition of, where we said 85,000, they would practice in communities of greater than 85,000.
What's the amendment? The amendment number is 13472. It doesn't make the bill, it adds,
Well, okay, then I guess it substitutes to the bill.
I'll move the amendment. It's seconded by Senator Hale.
That's right.
If you could describe the amendment, the population.
Yeah, what the amendment does, it just, it talks first of all about the licenses, how they're licenses, how the fees are selected. It does put that in there, how they'll practice in communities over 85,000 according to the the population in 2020. And then it talks about how they're regulated by them, and by the way, they are licensed by the Medical Board of Examiners, and what deals with license revocation and some of the technical details like that.
Okay, you've heard the amendment. Discussion on the amendment. Senator Hensley.
Thank you, Mr. Chairman. Well, how did the 85,000 population, is that something special about 85,000 population level?
I think yes, what it is that a lot of the smaller hospitals will only have a nurse anesthetist in them now, and for them to practice in a smaller hospital, because the law does require them to have an anesthesiologist work with them, supervising them directly. He has to be in the facility. And so many of those smaller hospitals are not going to have an anesthesiologist, and that was the reason they were excluded.
Okay. How many counties would that be? Do you know? That's several counties, but that applies to the county level, the 85,000 in the total county. It doesn't really look at how many hospitals or the size of the city or anything. It's just the county.
The law just says county.
But that 85,000, I mean, well, why not 100 or why not 50,000? Or I guess I'm just asking how the 85,000, it seems kind of like an odd figure. But
I don't have a good explanation for that.
okay. Okay, thank you. Thank you, Mr. Chairman.
Further discussion on the amendment. Seeing none, all in favor say aye. Aye. Any opposed? The amendment passes. We are on the bill. It's been moved and seconded. We do have testimony. If those in favor would come up and testify initially first and let us know.
I think we have Dr. Olive and
I
then
think the
Kelly Ray.
opposition wants to go first. Those in favor will go second. Sorry.
Okay.
So those in opposition, if they come before us, will go out of session to hear the opposition. Does go to calendar. Yes, if you would let us know who you are and who you represent, please.
Thank you, Mr. Chairman and members of the Senate Health Committee. I'm Tasha Alexander, and I represent the Tennessee Association of Nurse Anesthetists. And while we have 3 people up here today, we know that our time is limited to 3 minutes, so I'm going to introduce our speaker and then would obviously welcome questions on this bill. Hope Ferguson is our current Tennessee Association of Nurse Anesthetists president. She is a practicing CRNA and nurse anesthesia educator and veteran, so we think that she brings a unique perspective to this issue. So I'll turn it over to her to provide our remarks.
Good afternoon. I am here today on behalf of our more than 2,400 CRNA and SRNA members whose priority is providing safe anesthesia services to patients across the spectrum and across the state in rural and urban areas alike. This bill was brought under the pretense of addressing healthcare shortages and expanding practice providers available in the state. So how does AA licensure solve these issues? In short, it doesn't. This bill was not brought as a result of studies, stakeholder input, or evidence-based data based on Tennessee needs to address anesthesia shortages. It was brought as part of a national effort to expand AAs by physician anesthesiologists. It's worth noting that similar efforts have failed in Virginia, Arkansas, and Mississippi. AAs have not demonstrated the ability to scale to address shortages in any state contiguous to Tennessee outside of Georgia, where they created. Alabama passed licensure in '95. They have 19. North Carolina in 2007, 39. But even with 36% of the AAs in the country, Georgia still ranks behind Tennessee in the number of providers per population. AAs can't address shortages or expand access in the rural areas or address shortages in urban facilities with anesthesiologist shortages. AAs are required to practice under the direct supervision of physician anesthesiologists. So, where there is no anesthesiologist, there is no AA. CRNAs, unlike AAs, are not tied by medical direction by a physician anesthesiologist and therefore can provide anesthesia services to patients in rural communities. Currently, CRNAs are the primary providers of anesthesia services in rural counties throughout Tennessee, including 26 counties where they are the sole providers. Tennessee has 7 nationally accredited doctorate-level nurse anesthesia programs. These programs have over 500 BSN-prepared RNs currently enrolled. Nearly 180 nurse anesthesists graduate annually, and around 60% actually remain in Tennessee compared to the 300 AAs that graduate on an annual basis. Further, the accreditation body for the nurse anesthesia programs requires CRNA students to be supervised and taught by a CRNA or physician anesthesiologist. So for every room an anesthesiologist assistant is in, that is one less room an SRNA can be trained in. Clinical training opportunities for students will be negatively impacted, and there will be a downstream negative effect on rural areas. In fact, we are already feeling the impact of AAs from other states on our clinical sites. For example, Georgia SRNA students are being sent from Georgia to train here, even in Nashville. This displaces our Tennessee CRNA students from those clinical sites, forcing our programs to send our students to other clinical sites. We also have letters from other programs in other states that are based off experience. For the above reasons, the Tennessee Association of Nurse Anesthetists is opposed to this bill and is joined by over 250 physicians, surgeons, anesthesiologists, hospital CEOs, and administrators that signed an opposition letter to this bill. We urge members of the Senate Health Committee to vote no for AA licensure and the amendment. Thank you.
Thank you. Questions for the opposition? Senator Hensley.
Thank you, Mr. Chairman. So the main opposition is it would take away training sites, and CRNAs presently can practice in hospitals, or they in a hospital without a anesthesiologist. The AAs have to have the anesthesiologist, but it seems like that even the states where they've allowed them, there haven't been very many of them to come to the state. So, you know, that makes the argument, why oppose it? So, if there's not going to be many of them come to the state, do you think that if we allow it, that there would be several that came to Tennessee to practice?
My name is Dr. Andrew Rice. I'm the program director at Union University's anesthesia program. It all has to do with where the AAs can actually work. AAs can only work in larger hospitals with medical direction. Those are the hospitals that also do cardiovascular open heart cases, large neurological cases, and our students, all CRNA program students, have to go to those large hospitals to get those cases to graduate. When AAs come into the state, they only flood to those larger hospitals and take those cases. CRNA students cannot train in a room with an AA. Therefore, they're taking the ability for our students to graduate to get those required case numbers. That is why Emory is having to send their students here to train in those cases as well as pediatric cases.
And Senator Hensley, if I could, I would also offer that that's one of the concerns, the training and the detrimental impact to the CRNA pipeline. But I think the overall policy argument is that this was presented as a solution to expanding and increasing access and providers throughout the state. But if you look at what AAs are able to do, They're not going to be in rural communities, and rural health has been a real focus of this state because where there's not an anesthesiologist, there's not going to be an AA. Where you have physician anesthesiologist shortages, perhaps anesthesia groups that can't recruit or can't get an anesthesiologist to come into their practice, they're not going to be able to have AAs because also, again, where there's no anesthesiologist, there's no AA. And I think that there are very overarching discussions that we're willing to have about why we think that the infrastructure that we have in the state of Tennessee with CRNAs, we graduate more than 180 new students every year, 7 schools of nurse anesthesia is the solution that we should be looking towards because it is scalable and it's long-term.
Senator Hensley.
Thank you, Mr. Chairman. Is the pay for a CRNA and a anesthesiology assistant, are they comparable, or is there a big pay difference between the two professions?
Jim Almerding, CRNA, Knoxville area. Yes, sir, they are.
They are comparable?
Yes.
Yes, sir.
Okay. And the training aspect, the big difference between training between CRNAs and anesthesiology assistants is the experience that CRNAs get before they get the training, or is there much difference in the actual training that they get?
Absolutely. So CRNAs go to school for 3 years to earn a doctorate degree. They must have previous ICU experience in a high acuity ICU, managing patients on ventilators and drips. Therefore, they have a lot of experience going into CRNA school. And when they train in CRNA school, they're actually trained to practice independently, even though some of them may choose to practice in facilities with anesthesiologists. An anesthesiologist assistant can go from any degree and in 2 years practice anesthesia as long as they practice with an anesthesiologist. Therefore, they must be medically directed and they're taught to practice only in that model.
Okay. One more question, Mr. Chairman. Do you see an issue with CRNAs being under the Board of Nursing and anesthesiology assistants would be under the Board of Medical Examiners? Does that cause an issue?
Well, from our perspective, anesthesiologist assistants would receive their authority through medical delegation from the physician anesthesiologist. CRNAs as advanced practice nurses are not set up the same way. They are licensed directly and receive their certification through the Board of Nursing after meeting their licensure requirements as an advanced practice registered nurse. So we think that they are two completely different providers. And as we said, with AAs being tied directly to an anesthesiologist, and that's the only way that they receive their authority to practice, that there would, we don't want to go under the Board of Medical Examiners if that's what you're asking. But we think that they're two providers and they receive their authority differently.
Okay. I wasn't asking that, but I have proposed that in the past for different others. But thank you. Thank you, Mr. Chairman.
Thank you, Senator Hensley. Further discussion? Senator Yarborough is recognized.
Thank you, Mr. Chairman. And, you mentioned during testimony that a concern here is that if you have AAs practicing with anesthesiologists, that would inhibit CRNAs from getting the training they need to sort of become fully certified in order to act independently. Help me understand why that is precisely the case, and like whether and to the extent to which that is, sort of has that limited the the number of CRNAs in states that have both systems. Just I want a little bit of clarity on that point.
Yes, you're recognized.
Thank you, sir. So your question is, what is the impact on how they're not getting those clinical cases? Is that correct?
Well, I mean, I'm sort of
Yeah.
just asking,
So-
y'all made the point that
Right.
this could stand in the way of CRNA training, and I want to assess how serious a risk that is, and this and what the scope of it is.
Yes, sir. So the good thing is, we don't have to guess on the impact in the states around us. because we've seen it in several programs, which we provide the panel with today. 4 letters, one from Duke University, one from Wake Forest University, one from South College, and one from Western Carolina. And they all talk about the impact on getting those clinical cases in their programs. And one that stood out to me was Wake Forest, that because they have 22 students in the program, they're having to send those students all the way to New Mexico to get those clinical cases. Because for every room that a CRN AA is in, because our Council on Accreditation doesn't allow us to train AAs to train CRNAs because we train to be autonomous, that we must train our CRNA. So for every room an AA is in, that keeps that CRNA student having that opportunity to train in that room. Well, Wake Forest sends their students to New Mexico, and out of that graduating class of 22, only 3 stayed in the state after graduation to practice, because people appreciate the skill level that CRNAs have when they graduate, and then we're having to send them out of our state to go to other places, and people are recruiting them. South College, Tennessee-based company here in Tennessee that has clinical sites in both South Carolina, in both Florida and Georgia, because they were projecting not to get their minimum numbers for graduation. They're actually pulling their students out of Atlanta, Georgia, because of the competition for those cases. And I say competition, but I mean the ability not to get those cases. Because we're not going to allow our students to be unsuccessful. We're going to do our best to find clinical sites. And then Duke talks about some of the same experiences, and so does Western Carolina.
And I think it's also important to note that if AA licensure passes here in the state of Tennessee, then Tennessee becomes a clinical training site for AA students in other states. And so that is another factor that weighs in with not just AAs being here, but also the competition that's brought in with AA students coming from other places.
Yes, Senator Massey's recognized.
Thank you, Chairman, and thank you all for being here. We've received a lot of information on this topic for over a year, and and appreciate all that you all do to help in our health profession. And you've addressed a couple of my questions. I was interested a little bit more in the clinical training opportunities, and we have addressed that. But besides that portion of it, what else have we learned from the other states that have the programs? Is there anything that you haven't addressed that we have learned from those programs in other states?
One of the big things we have learned in those states that, and Dr. Hope Ferguson mentioned this earlier, Jim Alberty again, is that with licensure, the impact that they're hoping to have with this legislation hasn't generated the results they wanted to have. I mean, you look at Alabama, who's had AA licensure since 1995, only 19 AAs are in that state. North Carolina, I think, is 39. Then South Carolina is 40, and they've had since 2001. But the detrimental effect of this legislation on looking at those programs and how the students have not gotten to clinical sites, and how when you look at the percentage of providers per of anesthesia providers per 100,000 patient population, Georgia's ranked 28th in anesthesia providers per 100,000 population. It did not have the desired effect. Tennessee is ranked 10th right now, and we have the infrastructure in place. And one thing that I don't think we're talking about as far as the educational impact of these programs is what have we done over the last year to expand and work on workforce issues. You have 3 programs in the state that have increased the graduating class size, one specifically in Hamilton County, where last year's sponsor, Senator Watson, the bill came from his district. That program, it went from 48 last year to 73 this year, and has been approved by the Council on Accreditation for 90. And the reason why it's important to understand the process a little bit is because when we go for expanding our program size, we have to testify, or testify is probably not the right word, we have to attest to the fact that we have clinical opportunities for our students to do so. If we don't have those clinical opportunities, we can't grow. So by default, if we are having trouble with clinical sites, our programs can't grow. But over the last year, Chattanooga has grown, 2 programs in Knoxville have grown, and that growth, the 9 in the east and the potentially 42 in the west, in the same time frame that it would potentially take for this bill to roll out with licensure and all that kind of stuff, we will have those net effects from our in-state programs. And on top of that, there's 3 programs coming to our state right now that are working on expanding in Nashville. You have South College, who's looking at a program in Nashville. You have Vanderbilt that has an active job announcement open for a CRNA program director. Talking to, and then you have Merriam College, which has 12 students, which won't take a year. They'll be in place 6 to 12 students this coming year because they have a new clinical site in the Nashville area. So between the growth of our programs and those 12 students, that's more than 24. That's as much as what this bill fiscal note projects for the next year, more so, in growth than that bill actually projects. So why are we taking the chance of putting our programs in jeopardy when we've seen it in the other states? We don't have to guess. We see it and what's going on. Why are we taking the chance of putting these programs in jeopardy when we have new programs coming online and our programs are growing? But for accreditation purposes, we have to be able to attest to that we can have clinical opportunities for our students. And with AA licensure, the unintended consequences are the fact that it impacts our clinical site access. I think we have a great state. I think that's the reason why our students, want to be here, want to serve us. But if we have to send them off to other places, people are going to realize how good our students are. And the negative effect is going to be we're going to lose workforce for that same reason because they're going other places.
All right, I have Senator Reeves and Senator Hale. Senator Reeves is recognized.
Thank you, Mr. Chairman. I, like a lot of members on this committee, have friends on all sides of this, and I appreciate the efforts that have been made over the last year, few months to try to talk through and try to get to a compromise on this. From the very beginning, when I first heard about it, my question was, is there a need in the marketplace? And that really depends on who you talk to. You would think it would be math, but it's really, is there a need? I guess my hope was originally that putting a population threshold in place at 85,000 or another number would give you a little comfort, with the idea being that you would only be able to practice in much larger urban and suburban areas where there probably may any place have a more legitimate need. So does the population threshold not at all help resolve this for you? And if so, why not?
I'll start, if that's okay. We appreciate the question about the amendment and the population threshold. No, the short answer is no, because AAs, by their creation, and this bill are limited to being tied to an anesthesiologist. So from our perspective, the bill means that AAs are not going to be in rural areas initially. And so if you put a population cap in, that's essentially window dressing from our perspective, because they were not going to be in rural areas with the bill as introduced if there's not an anesthesiologist. When we talk about the 85,000 population cap, we Googled like everybody else can, and based on our research, that means the top 16 most populous counties in the state would be eligible for AA practice. That includes counties like not only your big counties like Shelby and Davidson that everybody thinks about, but Washington, Blount, Sullivan, Madison, other counties who by description of some would not be considered urban areas. And then you also overlay that with the fact that 6 of 7 of our nurse anesthesia programs are located in those counties. And primarily when you have those most populous counties, that's where your teaching hospitals and your tertiary hospitals are going to be located, which is where those specialty cases are going to be based primarily. And so you've actually concentrated the numbers of AAs there. So that's the short of it. I don't know whether anybody else, Andrew, or anybody else has any other comment.
One more small thing.
Yes,
So it's safe to say there is no population threshold that makes you comfortable?
No, sir. No. Unless you limited it to a state above 8 million. No, sir.
Senator Hale.
No, sir.
Thank you, Mr. Chairman. There are 7 programs in the state. How many students per year come out of those programs?
A little over 180, sir.
180, okay. How many, let me just ask the question. How many clinical rotation sites are available?
That would depend on each program. Each program is in charge of contracting with their different communities to find those sites and then get approval through the Council on Accreditation.
So can I make the assumption if you've got 180 students graduating from these programs each year, there's at least 180 sites?
I would have to go program by program. Like, for example, in Knoxville, and I'm not speaking on the program, but I'm speaking on behalf of myself, knowing the program. You're talking about five clinical sites, maybe 6 clinical sites. It just depends on the needs that you get from those clinical sites, which becomes very critically important. When we talk about the specialty cases, OB, cardiac, hearts, pediatric, and all that kind of stuff, that would bring your number down dramatically because those are your major teaching institutions that you get those cases for. So just because there's 180 sites, that does not mean there's 180 sites that they can get the training for those specialty cases to graduate that they need. Those are 2 different things.
And I think it's also important to note, Senator Hale, that because this is a 3-year doctoral program, that you have at any one time 500 students being trained at different points in their educational system. So I think that would be hard to narrow it down. So it's not just about 180 students that are there is a rolling number of students coming through, and that they're always actively trying to pursue clinical training opportunities.
Could I ask the gentleman from Union University what your figures are?
Yes, sir. So at Union, we share clinical sites. Some clinical sites, up to 5 schools, are in one clinical site. For our pediatric rotation, we share rotations with Emory and UAB from Alabama, as well as UT Memphis and Union and Arkansas. And so all those schools are in that one facility trying to get clinical training. They're pretty much capped out on how many students they could possibly take. Other sites, 3 to 4 schools will share one clinical site. So when we say 180 students are graduating, that's not 180 clinical sites. That's 180 ORs they could be in. And that's about how many we graduate.
Okay, and that's a 3-year program?
It's a 3-year program.
Over 3 years, they're in the clinical site for 3 years.
For 3 years. Yeah, currently we have 60 students rotating clinicals in year 2 and 3. Other schools rotate clinicals throughout the entire program, starting in the 2nd month, so they'll have more.
Okay. So the statement was made earlier that students would not be able to receive training if this passes because the AAs would be there. They couldn't train together. I don't understand.
Anesthesia programs are accredited by the Council on Accreditation. The rules is that CRNAs cannot train underneath an anesthesiology assistant. That's because AAs practice differently from CRNAs, and therefore they cannot train CRNAs because CRNAs have the ability to practice autonomously without anesthesiologists. Whereas if an AA was teaching them, they would only be able to teach them in the model that they would have to work with the anesthesiologist.
Okay. You use the terminology train under an AA. That's not a requirement, that would not be a requirement.
So whoever the supervising anesthesia provider in the OR, that's who's training the student. So if an operating room has an anesthesiology assistant in it, a CRNA cannot go into that operating room to do the case.
But they could if the anesthesiologist is.
If it was an anesthesiologist, they could.
Thank you.
Thank you. Further discussion? Seeing none, thank you. Now we will hear from the favoring side of the bill. Thank you for being with us. We are still out of session and recess. If you would, let us know who you are and who you represent, please.
Well, thank you, Mr. Chairman, and good afternoon, members of the committee. My name is Jeff Ollis, and I'm a medical doctor and a practicing anesthesiologist in Knoxville, and I'm also the incoming president of the Tennessee Society of Anesthesiologists. So at the beginning of my remarks, I would just like to go on record and say that I understand, based on what you've just heard, that there are some differences in opinion on this bill between the Tennessee Society of Anesthesiologists and the Tennessee Association of Nurse Anesthetists. I had the opportunity to speak with TANA leadership over the weekend, where we had a very collegial discussion about the implications of this bill, although differences of opinion still exist. But I just want to go on record to say before this body, just as I told my CRNA colleagues on that call, it's neither my position nor the position of the TSA that this bill is intended in any way to be anti-CRNA. I work with a phenomenal group of CRNAs in Knoxville, and like them, there are CRNAs all across our great state who provide an essential service to the patients of Tennessee. However, we're facing an unprecedented demand for anesthesia services in Tennessee and throughout the country. Simply put, there just are not enough anesthesia professionals in Tennessee to meet the demand, and that fact is indisputable. In my own hospital, about 30% of the CRNA positions are vacant. I've reached out to colleagues across the state, and I can report 2 of the Knoxville hospitals that have 27 and 12% vacancies respectively. There's an anesthesia practice in the Tri-Cities with a 17% CRNA vacancy, a practice in Nashville with a 13% vacancy rate. There's a practice in Chattanooga that has a 15 to 20% vacancy, while another has a 32% vacancy rate. One of the most commonly used online anesthesia job search forums currently has over 200 CRNA job listings posted for the state of Tennessee alone. The day-to-day reality for Tennessee hospitals and anesthesia practices is a constant struggle to cover cases. Sometimes this means operating rooms are closed and surgeries are canceled or postponed. Sometimes this means that off-duty clinicians must be recruited to work extra to cover the schedule. Oftentimes this means that vacant CRNA positions are filled with locum CRNAs who work through third-party agencies and travel to make temporary assignments. This type of coverage comes from outsiders, many of whom are from out of state, who do not have relationships with other members of the anesthesia department, with the surgeons or the hospital staff with whom they will work. And this type of emergency coverage comes with varying degrees of quality and a very high premium cost to the anesthesia practices and ultimately the hospitals where they provide service. Certified anesthesiologist assistants would provide another labor pool of anesthesia professionals to help ease these struggles in Tennessee, just as they already do every day in several other U.S. states, including 4 out of the 8 Tennessee border states. You may have heard that certified anesthesiologists are more limited than CRNAs by the practice model under which they must work, and this is true. But that does not mean that CAAs working under the medical direction of anesthesiologists cannot help expand access to anesthesia care in our state. They could, in fact, add to the available workforce in many Tennessee hospitals that are facing shortages of available CRNAs and help to cover their operating rooms. Licensure of CAAs might not benefit every single geographic area in Tennessee, and it might not fit the practice model or the culture of every single anesthesia practice across the state, but if there are anesthesiologist assistants that want to work in our state, and if there are Tennessee hospitals that could benefit from their service, should they not have the liberty to do so? You may have heard that CA training is inferior to CRNA training, that some schools of CA training programs include prestigious institutions like Emory University, Case Western Reserve University, Indiana University, just to name a few. I believe their quality of educational programs has been proven in multiple other states over many years since the very first training program opened in 1969. And I would personally feel, as a physician anesthesiologist, comfortable medically directing certified anesthesiologist assistants. You may have heard that CAA numbers are small and that CAA licensure in Tennessee will not generate sustainable growth in the anesthesia labor force, and that we should instead invest in expanding enrollment in existing CRNA training programs and opening additional nurse anesthesia programs. To that I say, why not do both? I fully support increasing the number of CRNAs trained in the state. I'm actually in discussions in my own practice with 2 new CRNA schools to increase the number of students that we have rotating through my primary hospital, as well as some of the other hospitals and part of my broader practice. We have, on any given day, probably 5 to 10% of the locations where we provide anesthesia services in our hospitals staffed with a student who is learning. We have a tremendous capacity to take additional students in our hospital, and we welcome that. That said, all these things will take time. If there are anesthesiologist assistants that are ready to go to work in Tennessee tomorrow, let's open the doors to them in whatever numbers they may come. CAs will not replace CRNAs, nor is that the goal. There's more than enough work to do for both professionals to coexist in Tennessee, just as they do in North Carolina, Georgia, Alabama, Florida, South Carolina, Texas, and many other states. Thank you.
Thank you, thank you. Discussion, questions? Senator Hill.
Thank you. I want to follow up with the same type of questions that I had previously. Is there a concern of the availability of clinical rotations of the training? Is there going to be a limit involved here? Go through the details of that.
Yes, sir. So on any given day in my primary hospital, my group covers, we have sort of 3 divisions. So at the primary location where I practice, we have about 40 sites a day where we provide anesthesia services, whether those are operating rooms, out of OR sites, operating rooms, and ambulatory surgery centers. And we have between 2 and 4 student nurse anesthetists rotating with us on any given day. So we have tremendous capacity to host more students. My hospital happens to be a high volume open heart surgery Hospital, which there was mention of that in terms of getting enough numbers of open heart cases. We do between 500 and 600 open heart surgeries per year. We could easily have more students, assigned to those roles for those learning opportunities. I believe that's probably true at many different places. It's true at the sister hospitals within my larger practice where I don't clinically work myself, but they're part of our group. We welcome the opportunity to have more students as one mechanism of trying to address this need, but it doesn't have to stand in isolation of the other. We think that can be part of the solution, just as having CAAs available to us as part of a labor force would also be beneficial. And I'll speak specifically to the issue at Wake Forest. So I actually went to medical school there. I graduated from Wake Forest. And so Wake Forest has one of the best anesthesia residency training programs in the world, frankly. Their open heart surgeries are staffed by anesthesia residents as well as fellows who are anesthesiologists that are doing additional training after residency. I did a cardiac fellowship myself in order to subspecialize in the anesthetic care of the sickest heart patients. I don't think the fact that anesthesiologist assistants have been licensed in North Carolina is the reason why student nurse anesthetists at Wake Forest are having to go elsewhere. I think those cases from the time that I was there, my own personal observation, were always staffed by residents and fellows. And so I don't think that CAA licensure is what caused that, just from my own personal experience there.
Senator Yarborough, then Senator Reeves.
Thank you, Mr. Chairman. I think Senator Hale raised the real question I have, because I think the training issue to me is an important one. It's like the goal here is that you've stated is to increase the number of professionals, and so if there is some sort of barrier that actually stops some of those people from becoming anesthesia professionals, it could be counterproductive. But is your testimony that is not, you don't view that as a concern?
Certainly, we have a difference of opinion on that matter, but I do work at a hospital where we host student nurse anesthetists from 2 different schools, and so I can speak to the hospital where I work as well as the 2 other hospitals that are part of my larger practice, and I can say that we have the capacity to host more student nurse anesthetists than we currently do, and we're actually in active discussions with 2 new schools in Knoxville that are developing nurse anesthesia training programs to bring their students on board and let them rotate through our hospitals.
Thank you, Senator Reeves.
Mr. Chairman, when I first heard about this concept, my first thought was that AAs just made a lot less money, and it might make sense to try to build them throughout the state, and it sounds to me like they don't. At least that's what I was told today. And then the second question was, is there going to be a need? Is there anything else that we're missing today that's causing you to feel so strongly about this bill? Is there any other advantages to AAs other than the fact that we just have a capacity issue in your mind?
No, for me, thank you for the question, but for me, it's strictly an issue of access to care. We do not have enough anesthesia professionals to meet the demand, and we deal with this on a daily basis. I've cited multiple different hospitals where I have colleagues that are all dealing with the same thing. So, again, it's not my position. This is in any way intended to be anti-CRNA. I love working with CRNAs. I respect them tremendously. They provide an essential service, and so this is strictly from my point of view. There aren't enough CRNAs. This is access to another, anesthesia professional that could join our workforce in Tennessee and help us to meet this unmet demand.
Senator Hale.
Thank you, Mr. Chairman. I want to come back to this training again. We've heard testimony that the CRNAs cannot be in the same, I may be translating this incorrectly, but cannot be in the same clinical practice, same room as an AA is in. Tell me how you separate that in your hospital. Do you just answer that question for me, please?
So at present, we have no anesthesiologist assistants. There are only CRNAs in my hospital working under the supervision of an anesthesiologist. And so students who rotate at our hospital, can go into the operating rooms. And so I don't want to speak for them, but I believe the concern that's being expressed is that in my group, hypothetically, if we were to hire anesthesiologist assistants and we had a certain number of operating rooms where I was, instead of supervising a CRNA, I was supervising an anesthesiologist assistant, students rotating through my hospital would not be able to go in those rooms and work under their clinical guidance. And I think that's legitimate, but I think that there's no, chance with the number of AAs that exist across the entire country, let alone the number that are going to come to Tennessee, that we're going to have a substantial impact on the opportunities for the students to learn. Again, in my hospital, we have between 2 and 4 right now, and we're providing anesthesia in 40 different locations a day. So, you know, in any given day, there are 36 to 38 more rooms that a student nurse anesthetist could go in. If we hired 10 CAAs, we would still have a plethora of rooms in which they could go and get training.
Thank you. Further discussion, Senator Hensley.
Thank you, Mr. Chairman. Do you think that the training is comparable that the AAs get to, and the CRNAs? Do you think the experience that CRNAs have initially is that important, or is the training comparable?
So I think that, you know, as has been illustrated and articulated already, I mean, the training pathways are different. In my mind, I think the anesthesiologist assistant undergraduate, you know, the education that they get prior to going to AA school is not too dissimilar from that of our PA colleagues that are in the room today. So it's not a nursing background, it's sort of a pre-medical background. I have not, you know, we've never had AAs in Tennessee, so I've not had the opportunity to work with them myself, but I do have colleagues in other states, several border states of Tennessee, who work with them, and they have reported to me that they have not found a difference in the day-to-day working with them, that they find them very competent and capable, and they enjoy working with them just as they do enjoy working with CRNAs.
Thank you. Senator Hensley?
One more question, Mr. Chairman. And you were mentioning about the vacancies earlier. Different hospitals had different vacancies for CRNA, so I assume there's vacancies for anesthesiologists as well, or is that just CRNAs that they're looking for and not anesthesiologists?
There's some of both. There have not been enough anesthesiologists to meet the demand in this country going back, you know, prior to my career, probably 1990s and beyond. So very commonly, anesthesia in this country is delivered in an anesthesia care team model, where one anesthesiologist is supervising a certain number of CRNAs. You know, there are demands for anesthesiologists as well, but you know, you really, because of the model in which anesthesia care is delivered, you need a lot of CRNAs, and there just aren't enough of those by comparison.
Okay.
Thank you, Senator Hensley. Senator Yarborough recommended that we hear from, are you an AA? Yes, you are recognized. Let us know who you are and who you represent, please.
Good afternoon, Chairman Crow and members of the committee. Thank you for allowing me to speak to you today. My name is Kelly Ray, and I'm a certified anesthesiologist assistant in strong support of SB0453. This bill would give licensure for CAAs to work in Tennessee. I'm president of the Tennessee Academy of Anesthesiologist Assistants, and here today to represent the many CAAs from Tennessee that want to return home to their families to work in this great state, as well as others that would love the opportunity to move here. I received my undergraduate degree in biochemistry pre-med in Tennessee at Lee University, where I met my husband, who is a native Tennessean, and he still works in Tennessee. I then attended Emory University School of Medicine to obtain a Master of Medical Science and Anesthesiology degree. So like they have said, the educational paths to becoming a CAA include completing rigorous pre-medical coursework, earning an undergraduate degree, and taking the MCAT or GRE exam. These master levels programs are 24 to 28 months in length, and students receive comprehensive didactic, simulation, and clinical training necessary to become safe anesthesia providers. Upon graduation, CAAs have completed an average of 2,500 clinical hours and administered more than 600 anesthetics. These totals are almost identical to that of our CRNA colleagues in their postgraduate anesthesia-specific training. Students must pass a national certifying exam administered by an independent certifying organization. CAAs must complete 50 hours of continuing medical education every 2 years, along with a recertification exam every 10 years. CAAs provide safe anesthesia care in some of the leading hospitals in our country, including Emory, Johns Hopkins, and the Cleveland Clinic. A 2018 study by Stanford Medical School compared CAAs and CRNAs working in the anesthesia care team and found no significant difference in mortality, length of stay, or spending between the two providers. Another study by the American Society of Anesthesiologists concluded that differences do exist between AAs and CRNAs with regard to prerequisites, instruction, and requirements for supervision, as well as maintenance of certification. These are the results of different backgrounds associated with the two professions and the stated preference of anesthesiologist assistants to work exclusively on teams with physician anesthesiologists. However, the committee found no evidence that any of these differences result in disparity in knowledge, technical skills, or quality of care. CRNAs and CAAs are both advanced practice providers, and we work interchangeably in hospitals across the country. I've been practicing as a CAA in Georgia for 7 years, where CAAs have been licensed for more than 50 years. We are safe, effective, and qualified solution to the staffing shortage, and every other medical specialty in this state is allowed to work with both nurse practitioners and physician assistants. Anesthesiologists and hospitals should have the option to operate with both CRNAs and CAAs as well. I have the same job responsibilities, same salary, and same benefits as my CRNA colleagues, and we work together cohesively every day in the operating room. So please support this bill because CAAs are highly trained providers and ready to move our families back home to Tennessee.
Thank you.
Thank you.
Appreciate that. We need to get Senator Briggs to his appointment, but discussion, further discussion while we're in recess. Senator Hensley.
Thank you, Mr. Chairman. I'm just wondering why you would go the route of the AA when you live in Tennessee and want to come back to Tennessee and knowing that AAs aren't licensed in Tennessee. Why not go ahead and be a CRNA?
So I always knew that I wanted to go into the medical profession, but I chose an undergraduate degree in biochemistry because I wasn't sure if I wanted to go to medical school or PT school or PA school. And near the end of my undergraduate degree, I came across the AA profession and already had all of the prerequisites. And I shadowed in the OR, and I fell in love with the career. So that at that point, I had the option to go to medical school and become an anesthesiologist, which would take the same amount of time to go all the way back to nursing school and then become a CRNA from where I already had a 4-year degree. So it just made more sense for me to go to an AA program.
Okay, but you realize that AAs weren't licensed in this state, though. That's the thing.
Yes, sir.
Okay. Okay, thank you.
Thank you. Further discussion while we're in recess? Seeing none, thank you so much, both opposition and those for the bill. Appreciate you.
Thank you.
We are back in session. The amendment has passed. We're back on the bill. It's been moved and seconded. We are on the bill. Discussion on the bill. Seeing none, Mr. Secretary, if you would call the roll on the bill.
Senator Hale. Votes aye. Senator Hensley. Votes no. Senator Jackson. Votes no. Senator Massey. Votes aye. Senator Reeves. Votes aye. Senator Swan. Votes aye. Senator Watson. Votes aye. Senator Yarborough. Votes aye. Chairman Crow.
Rule 13, aye.
Votes aye. Mr. Chairman, you have 7 ayes, 2 noes.
Chairman, I need actually Rule 13 times twice. I'm on a hospital board and a college and nursing board. So actually, I could declare Rule 26, but I meant to do that.
Rule 26 for Senator Massey. Okay, thank you, Senator Briggs.
Yeah,
We appreciate
thank you
your
very
work
much,
on this.
Mr.
Thanks to
Chairman.
both sides. Yes.
Yeah, thank you very much, Mr. Chairman and
Thank
committee
you. Hope you
members.
make it to your appointment.
Okay, I will.
You're close. You're pretty close.